joining us for a wellness webinar series event with Jefferson Health. My name is Sarah Breckbill, and I will be serving as your program facilitator and will present your questions to our panel of experts. This evening, Jefferson Health experts in OBGYN will answer your questions from bump to birth. Well, thank you for submitting your questions in advance. And the questions that you'll hear me asking the panelists tonight are all submitted right from when you registered for this webinar. The submitted questions have been grouped into 4 different sections: preparing for pregnancy, getting pregnant, during pregnancy, and labor and delivery. If you have any questions throughout our discussion tonight, for those joining us on your computer or tablet, at the bottom of your screen, you will see an icon that says Q&A. Now, we'll do our very best to get to as many questions as possible, but may not be able to answer all of them during this virtual event. And due to hospital university guidelines and privacy, we are unable to comment on specific cases. Likewise, if you're experiencing any symptoms that may require immediate medical attention, please consult a medical professional. So without further ado, let's go ahead and dive into it and introduce our experts for the evening. And I'll let each one of you go ahead and say a little bit about yourself. So let's start with Lanice Coleman, certified nurse midwife. Hello, Lanice. How are you doing tonight?
Hi, thank you. My name is Lanice Coleman. I am the manager of midwifery services in Center City. I've been a midwife for 22 years. I'm very happy to be here with you tonight.
Yeah, and we're happy to have you. Thank you. Okay, next up is Dr. Mackenzie Purdue, and a special shout out to you as we know you're on call. So thank you for taking the time to join us. How are you? Oh, and it looks like you might be on mute.
Thank you for that. Hi, I'm Dr. Mackenzie Purdue. I've been at Jefferson for 8 years, but I'm a newer provider here after training. And I am on call tonight, so if I leave suddenly, that is why, but I will try to join back after.
Great. Well, thank you. Okay, next up is Dr. Corey Johnson. Hello. Oh, and looks like you might be on mute as well. We'll get the hang of it.
Maybe. Hello, I'm Corey Johnson. I am currently practicing at Jefferson Einstein, seeing patients there. So I just got started this year.
Great. Well, thank you for joining us. And finally, last but not least, but Dr. Whitney Jolitz, how are you doing?
I'm doing great. Thanks for having me. I'm Dr. Whitney Jolitz. I did my training in Jefferson, New Jersey. I left for a few years and have recently started back up. So I've been practicing for over 5 years, and we deliver at Washington Township, so we'd be happy to have anyone.
Great. Well, thank you all for taking the time to introduce yourself. And I think let's go ahead and get into some questions, because I know we received a ton of great questions. So it'll be a terrific and engaging discussion tonight. Okay, so to start us off with, we will hop into question number 1, which is about egg freezing. So Dr. Purdue, I will turn it to you. Can you briefly discuss the process of egg freezing, and when is an ideal time to go through the procedure, and any potential resources you could share? And if you could unmute yourself.
Got it. There we go. Yeah, so egg freezing is something that is an option for patients who know they want to be pregnant in the future, but might not currently have a partner, and might be worried that they might not have a partner or pursue pregnancy until later, late 30s, 40s, and would like to have those eggs available to do that. This is usually done by our reproductive endocrinology subspecialists. So they're OBGYNs that did additional training in infertility and reproductive endocrinology. And so with Jefferson, I know we work closely with a group called RMA. Sorry, just had a brain freeze. Egg freezing is something to start thinking about likely in your 30s. There are other medical conditions that might prompt you to think about it sooner. And so that's a little individualized. The REI, or the reproductive endocrinology sort of research, shows that patients who freeze their eggs at 37 usually get a great amount of eggs and also are more likely to use them. So when they pay to store them, they're most likely to use those eggs. The earlier you pursue egg freezing, the more eggs you might retrieve per cycle, and the healthier those eggs might be. However, that sweet spot of actually using them has been shown to be between 35 and 37. The earlier you do it, the more eggs you might get. But again, there is some storage fees and such with storing eggs to think about. Another thing to think about is, insurance. It's good to look at, especially if you have insurance through your employer. Sometimes you can upgrade your plan with your insurance to help cover the cost of egg freezing. So that's something to consider if that's, before you even meet one of the doctors to go through this, to try to help evaluate what the cost might be, depending on your insurance. And the process is sort of like the first half of an IVF type process, which is in vitro fertilization. So you'll be using hormones to help your body sort of formulate the eggs, mature the eggs, many eggs at once. When you have a normal menstrual cycle, you sort of mature one egg at a time. But with these processes, you're using hormones to try to recruit many eggs at once. And then the reproductive endocrinology doctors sort of use lab tests and ultrasound imaging to find the perfect time to use a procedure, usually done vaginally, to retrieve some of those eggs. But that's something that would be explained to you, their exact process when you would meet with that type of doctor.
Okay.
Well,
I know a lot of think through, so we appreciate you walking through us. Okay, we'll go to our next question here. Dr. Johnson, this one is for you and talking a little bit about PCOS. So how should someone with PCOS prepare for pregnancy?
Got myself there. Okay, so PCOS is definitely a condition that we see frequently. It's one of the most common conditions that can affect your fertility, but there's still plenty of people who have PCOS who are able to go on to get pregnant. We don't understand PCOS fully, but what we do know is that there's an imbalance in hormones that frequently causes a change in how frequently you're able to ovulate. And obviously, if you're not ovulating, you're not going to be able to get pregnant. In terms of preparing for pregnancy, we know that weight loss can have a really big impact on people who are symptomatic from their PCOS or not ovulating. Losing 10% of your body weight has been shown to reduce symptoms of PCOS and improve fertility. So that could be things like increasing the number of times or the duration of your exercise, making diet changes to include more vegetables, more not including refined sugar or carbohydrates, and then choosing lean meats or other plant-based sources of protein, or even cutting out alcohol. All of those things could help you with weight loss. For somebody who has PCOS, is making those changes and still isn't successful in their pregnancy journey, sometimes at that point you need a medication to help your body ovulate, which could be prescribed by either your OBGYN or by one of those REI specialists that Dr. Purdue was talking about with that last question. It's also worth mentioning, though, that even if you do have PCOS and you aren't planning to get pregnant right away, you definitely are still you could still be ovulating at some points. So it's important to have contraception in the event that you're not ready to get pregnant at that time.
Okay. Thank you so much. All right, we will move to our next question here. Dr. Jolitz, this one is for you. Talking a little bit about fillers and Botox. So for someone who's planning on getting pregnant in the next couple of months, should they be getting fillers, Botox, and even dental fillings now before they're getting pregnant? And also, could you just talk a little bit about during pregnancy as well?
Definitely. So we'll split it up into two. So dental care. So I always tell patients your dental health is just as important as the medical issues you might have. So it's very important to address those issues before, during, or after pregnancy. Of course, anything, whether it's dental or medical health, anything that could be addressed before pregnancy would be ideal. But if that can't happen, or if those problems arise, I definitely encourage people to seek dental care, whether that's just a dental cleaning or you have a filling or a crown or anything that needs to be addressed. It usually can, it can be safely addressed during pregnancy. And all the time I'm either sending letters or talking to dentists about things that are safe during pregnancy. So sometimes you need antibiotics if you have an infection. Lots of antibiotics are safe during pregnancy. You might need an x-ray. They can shield your belly, or that can be delayed till after the first trimester if there are concerns, but that can be safely done. Most dental procedures are done under local anesthesia, so you're not getting, that's not going throughout the whole body or affecting the pregnancy, so that can be really easily addressed. So, we always encourage good dental health during pregnancy. So that's an easy one. Botox and fillers are, cosmetic, so meaning not medically necessary. They've never really been studied in pregnancy because, you don't necessarily really need them. Botox is botulism. It paralyzes the muscles. So it's usually not recommended, definitely not recommended during pregnancy. Depending on how frequently you get it or the dose you get it, depends on how long it stays in the system, but on average, it stays about 3 months. So if you are planning a pregnancy, maybe get your Botox done 3 months before you plan on getting pregnant. If you got it and then happen to get pregnant, I'm sure that would be a low concern for that during the pregnancy. But if you're planning it, ideally, maybe wait a little bit after you get it done. Fillers can be permanent. So you might have had, fillers that are never going to go away or degradable. The concern with fillers during pregnancy is, local swelling and hormonal changes. So we definitely don't recommend those during pregnancy as well. So, luckily those can be, done after pregnancy. So.
Okay, thank you. Some helpful tips to keep in mind. So thanks for detailing that for us. Okay, Lenise, we will turn to you for our next question and talking a little bit about doulas. So what role does a doula play, and how can they help in the planning process during pregnancy and even during labor?
So traditionally, the doula is a trained labor support person, although in recent years, we're starting to see postpartum doulas, doulas that help in the death and dying process. But what we most often, the people we work with are trained labor support people. They've been studied extensively and have been found to be associated with lower risks and lower C-section rates in birth. Ideally, this is someone you meet ahead of time, and a lot of insurance companies now cover doula services. But this is someone you want to develop a good relationship with. They are there to work solely with you and your support people. Oftentimes your support people care deeply and want to support your goals in labor, but may not have the necessary skills and knowledge to do that effectively. Sometimes they're afraid because they're seeing you in discomfort. But a doula is someone who is used to dealing with labor and has some knowledge about positioning and different comfort measures to use throughout labor and birth, and they're your advocate. So this is often someone who will also help you develop a birth plan. If you're delivering in a hospital, come to the hospital with you, help you stay on track with your birth plan, advocate for you with your providers. And again, like I said, they're someone who's there to exclusively be with you, whereas your healthcare provider may be coming in and out of the room. This person is there exclusively for you. And we highly recommend the use of a doula.
Okay. Yeah, I like that description of being an advocate. So that's great. Okay. Our next question here, Dr. Johnson, or actually, sorry, I'm skipping over Dr. Purdue here. Our next question, Dr. Purdue, will turn to you. How long before trying to get pregnant should you see a psychiatrist who specializes in pregnancy treatments for mental illness? And additionally, are there certain medications that may not be safe to take?
Yeah, so I'm not aware of too many psychiatrists that care for, specialize in pregnancy. This is usually, most psychiatrists are aware of some medications that we try to avoid in pregnancy. And it's definitely a collaborative effort between your psychiatrist and your OB provider. So the earlier that you can make both providers aware that you're interested in pregnancy, the better off, because if there are medications you're on that we don't want you on during pregnancy, we would want time to switch those medications and make sure your symptoms and your illness is under good control prior to pregnancy. Like many illnesses, sometimes we don't have, you're pregnant spontaneously before you're able to do these things pre-pregnancy. So letting, your OB provider and your psychiatrist know as soon as you're pregnant is also advised. The most important thing with mental illness and pregnancy is the better controlled it is before you even get pregnant or early in pregnancy, the better off everything is and how you'll feel throughout the pregnancy. And so we really recommend a lot of times sticking to your regimen that's been working as long as everything is safe. I don't want to go through all the individual medicines here, but that is a list to run through and talk with both providers and see if there's options to switch if needed, based on the type of medicine you're on and the illness you're treating. More common medications like our SSRIs, which are used commonly for anxiety and depression. Most of those are safe and, we use in pregnancy. We don't have a lot of data to say what effects they have in pregnancy, but anecdotally and based on our experience and use, we've not seen any huge issues and tend to continue those throughout pregnancy. There are some small exceptions that could go through on an individualized basis. The medicines we're concerned about, could it put you at risk of some certain birth defects. So if there were any concern about exposure during pregnancy, then you're usually linked with a maternal fetal medicine provider, also called an MFM, that will help do extra monitoring for any concerns relevant to that medication.
Okay, thank you. All right, we will turn to our next question here, but sounds like just having those initial conversations with both providers is very important. So, okay, Dr. Johnson, we will turn to you now. How do you counsel patients who have experienced a loss, and when should you start to think about trying again? Additionally, what is the best way to prepare for pregnancy after a miscarriage, and any resources that might be available that you would recommend?
Yeah, this is a really important question because pregnancy loss is challenging, but it's also really common for any person who's in the process of starting their family. It might seem high, but up to 10% of all pregnancies end with pregnancy loss. And the majority of those are in the first trimester. So for anybody who's listening who has experienced that, you're definitely not alone. Of those first trimester losses, a lot of them happen because of abnormal genetics, which is a completely unpredictable and spontaneous occurrence, nothing that anybody has any control over. For people who've experienced 3 or more losses, we do recommend that you reach out to your OBGYN, have that discussion with them, because there's additional testing and blood work that we do to see if there's something else going on. Is there something that we can identify that we could maybe assist with to prevent further losses in the future? And then for somebody who has recently experienced pregnancy loss, the next steps are really up to them. Some people want time to process and grieve their loss. Others are ready to move forward and try again as soon as possible. And there's really no right answer. It's whatever you feel is best for you. There's no evidence-based recommendation for the amount of time you need to wait to attempt to conceive again. It is important to know that ovulation can occur soon after, like less than 2 weeks after a pregnancy loss, especially if you had any procedure done to remove the pregnancy tissue. And so then it's important, if you would like the additional time, that you talk with your doctor about contraception options to give your body that time. The good news is for people who have experienced pregnancy loss, 75 to 85% will go on to have a successful pregnancy. And then in terms of support groups, with social media, there's so many options. You can find groups on Facebook that have hundreds of thousands of people like the miscarriage and pregnancy loss group. And if you want to see more stories of success, you can go onto Instagram, search the hashtag Rainbow Baby, and you can see some really beautiful stories there. I want to say October is Miscarriage and Loss Awareness Month. So there's definitely now more than ever people who are out there sharing their stories and ready to talk about their experiences if anybody wants that personal connection.
Hey, thank you. And your note about those not being alone, I think is very important. So thank you for sharing that. Okay, we will turn our discussion here to talk a little bit about diet and exercise. So Lenice, what diet and exercise suggestions do you have to prepare for pregnancy?
Well, the good news is if you're already following a pretty healthy diet and exercising, you really don't need to do really anything different. The USDA now uses a food plate to recommend healthy foods consisting of like mostly fruits and vegetables, whole grains, sources of lean protein, and dairy. And that's easy to Google and find out recommended amounts of different foods. And in the early pregnancy period, you may find that certain foods work for you and other foods don't. And you have to tailor your diet to how you're feeling. And the same thing goes with exercise. We highly recommend exercise during pregnancy, certainly being in good shape and maintaining a healthy body weight can impact your ability to get pregnant. But exercise is recommended throughout pregnancy. Some things that people ask about are what are my limitations during pregnancy, and really not working out in excessive heat is important. Staying really well hydrated is important. When you're showing, as a lot of people talk about, around the 20 to 24 week mark, your abdomen is a little more at risk. Your balance starts to change. So we don't recommend you do things where balance is important, or falling and hitting your abdomen could be more traumatic. So riding a bike, skiing, anything that requires good balance. Also, when the abdomen is larger, we don't want you to lay completely flat on your back. We want you to have a side tilt or be elevated a little bit. We don't want the full weight of your uterus and the baby to be pressing down on your abdomen and the vessels that supply blood back to your heart. And we don't want you to be so out of breath that you can't talk at all. That could suggest that your heart rate is maybe a little too high and you could be at risk of getting overheated. And again, towards the end of pregnancy, maybe lifting very heavy weights over your head. We just don't want to risk someone dropping a weight and having a hit to your abdomen. But really, we highly recommend exercise. If you're new to exercise, talk to your provider before you start a new program. There are very few people who shouldn't work out during pregnancy, and that's something your provider would talk to you about if you have a pregnancy or health condition that would limit your ability to exercise.
Okay, thank you. All right, so talk to your provider, but it sounds like working out for the most part is good to continue. So thanks. All right, Dr. Jolitz, we will turn to you, talking a little bit about prediabetes. So would you recommend an anti-glycemic therapy for a pre-diabetic before getting pregnant to avoid a high A1C?
So usually we don't. So I just want to start for people, patients who are here who might not know what prediabetes is. So that's basically before you've been diagnosed with diabetes. So your blood sugar is high, but it's not high enough. So usually that's a fasting blood sugar that's above 100, but less than 126, or you've had a hemoglobin A1C, which is a measure of the blood sugar on your red blood cells over 3 months. And that's usually from, 5.6 to 6.4. So those are elevated, but not high enough. There are many benefits to having well-controlled blood sugar leading up to pregnancy and during pregnancy. But since we're talking about before pregnancy, that effect would, the immediate effect that would have on an early pregnancy that we're concerned about would be congenital anomalies, or these are things that alter how the baby forms early on in pregnancy, which then are present at birth. So, we always talk about good blood sugar control leading up to the pregnancy, mostly because of that's the biggest issue. So the goal for someone before they get pregnant or preconception blood sugar, hemoglobin A1C is 6.5% or less. And so that is within the pre-diabetic range. So if you are technically pre-diabetic, you're already within that recommended range. So if you are pre-diabetic and not on medications, I wouldn't necessarily recommend that you need to start it if you're within goal range. One consideration might be if you're pre-diabetic and you have PCOS, a lot of those patients get started on metformin, which Dr. Johnson talked about earlier. So if you were, pre-diabetic and on, had PCOS and you already started on metformin, or wanted to start it, that might be a consideration, but you don't necessarily need to start medication. If you were already on something else besides metformin, like insulin or glyburide, or, we would just make sure those are safe or possibly change those before pregnancy, but don't necessarily need to start those. One thing I want to point out is, a lot of patients think that, going in well controlled, they'll stay well controlled during the pregnancy. And that's unfortunately not necessarily the case. Whether you're not diabetic or pre-diabetic or diabetic, your insulin resistance will increase during the pregnancy. And so you will likely, you'll be tested for that and you'll be monitored, but you might eventually need to be started on medications where you didn't before, depending on how your body handles the sugar, your high sugar during pregnancy.
Okay, thank you. All right, we'll turn to the next question here, talking about conceiving. So Dr. Purdue, this person is wondering, what should be my first appointment or step after not having success in conceiving after a year?
Yeah, so after a year of trying, more than 90% of people usually are successful at conceiving. And so if that does not occur, especially under the age of 35, first stop could be at your OB doctor. If you've already had a referral or are able to go directly to a reproductive endocrinologist, that could also be an option for you. But sometimes you might need to see a general OB provider first, and sort of start that evaluation, and then have a referral to reproductive endocrinology if appropriate. If you're above 35, I wouldn't wait a whole year. 6 months is usually when we recommend bringing to your OB/GYN's attention that you've been trying and you've not yet conceived. And so that evaluation might be started a little sooner if you're above the age of 35. Yeah, that's the main thing is, alerting your GYN doctor, and they will try to get you connected with a reproductive endocrinologist if that is indicated.
Okay. All right. Lenice, we will turn to you about tracking ovulation. So what is the best and most accurate way to track ovulation days?
Well, we've gotten really sophisticated in recent years. There are lots of different ways. What we know is that most people ovulate about 14 days before their next period starts. So you can't necessarily use the days of your cycle the first month that you're trying to track your ovulation. You do need to keep track for a few months. The average person's cycle is different for each person. Anywhere between 21 to 35 days is normal. And that can vary for the same person from month to month. But usually you ovulate about 14 days before your next period starts. So if you start to notice a trend in how long your cycles are, you can start to predict. We know that sperm live in a person's body for 4 days on average, 3 to 4 days on average, and so there are probably about 5 days that you're fertile during an average cycle. Some people rely on their cervical mucus to tell when they're ovulating, and throughout the cycle, your discharge from your vagina changes. And around the time you're ovulating, you may notice a discharge that is more stringy, like a raw egg white. We're very lucky now. We have ovulation predictor kits that you can buy at any pharmacy or online. They can be costly. So, sometimes people start to rely on tracking their cycles every month, and checking their cervical mucus so that they kind of have a better idea when to use ovulation predictor kits. And now, you know, there's apps that you can keep on your phone that can also assist in keeping track of fertile days.
Okay. Yeah, I was gonna say, I know there's plenty of apps too, so a lot of options. Okay, thank you. So we'll turn to Dr. Johnson now. Dr. Johnson, what suggestions do you have for a diabetic woman who has had successful sugar control on Ozempic or maybe a similar drug that wants to get pregnant? You caught yourself.
I'm working on it. So Ozempic definitely has been in the news a lot lately. We know that it's effective for people who are diabetic looking to control their blood sugars, and we know that people are using it for weight loss as well. But for pregnant patients, it is not considered a safe medication. We don't have any validated studies on pregnant humans to show that it's safe. And there are animal studies that have revealed some concerns for fetal anomalies or even pregnancy loss. So it's something that we would like to avoid in our patients who are pregnant. We also recommend that patients stop it 2 to 3 months before they start to conceive, just because it is something that can last in the system for a longer period of time. And it's not a medication that we want you to stop cold turkey. So definitely speak with your provider if you're planning on conceiving so that you can appropriately taper down the medication. Dr. Jolitz sort of got into this a little bit with her previous question about pre-diabetes, but we do know that there's many medications that can help control blood sugar in pregnancy, typically using both short and long-acting insulin. And like she said, there's so many hormonal changes that are happening. It's very common to see a change, typically a worsening in blood sugar control because of those different factors. So typically you're a patient who had been on any sort of medication for diabetes in pregnancy will at the very least see a high-risk OB specialist and MFM at some point and may exclusively receive their care from that high-risk group because of that complication.
Okay, thank you. All right, Dr. Jolitz, we'll go to you next and talk a little bit about birth control here. So this person is wondering, I'm looking to have a baby after being on birth control for many years. Do you have any advice on what to expect after stopping birth control?
I get that question a lot in the office. I just want to spread the, awareness that birth control has never been shown to decrease your fertility. You know, if you've been on it for 10 years and all of a sudden you're trying to have a baby in your late 30s, it's because you're older and not younger. So please let people know that birth control is perfectly fine for you to be on it as long as you want. I get that question like, I've been on something for 5 years. Should I come off of it? But I'm not ready for a baby. Absolutely not. Please stay on it. What to expect depends on what birth control you're on. So if you're on the pill, which is, most common birth control, a patch, a vaginal ring, or the Nexplanon, which is the implant that goes in your arm, most of those show that your ovulation will return very quickly, meaning releasing an egg. So within a few months, at the very least, you should be seeing regular periods because the periods you were getting with those birth controls were not necessarily real periods. You were getting those from withdrawing from the medication. So you should see a period that you induce yourself very quickly after stopping those medications, at least by a few months. So, if you're pushing 3 months plus and you haven't seen a period, you definitely need to let your provider know. IUDs or intrauterine devices are a little bit different. We place them in the uterus. For some patients, they do stop their ovulation, but that's not necessarily how they work. They work locally. So most patients will continue to ovulate or release an egg while they have the IUD. So when that IUD is removed, you could ovulate very quickly and get pregnant very quickly after that. So, I always tell patients, if we're removing it, are you ready? Because, you could get pregnant pretty fast. So if some people take the IUD out and then maybe they use condoms for a few months until they're ready, or if they want to see, if they weren't seeing a period with the IUD, they maybe want to wait and help that period, wait for that period to regulate. Depo-Provera is, most patients probably know what it is. They get the shot every 3 months. It's a higher dose birth control. It can suppress your ovulation for several months, even after you stop it. And that depends on how long you've been on it. So I've seen patients maybe up to close to a year before they start seeing regular periods after they stop the Depo. So if you are interested in getting pregnant in a few months and you've been on the depot for a while, maybe you come off and use condoms or use something else until you're a little bit more ready to get pregnant. If you want to stop and then you're fine whenever you want to get pregnant, that's fine. But you need to be aware that it could take a little bit longer before you start to ovulate on your own. So it just, really kind of depends on what you've been on, but doesn't mean you need to come off of it if you're not ready to have a baby.
Okay. Yeah, I think that's helpful to hear that you're okay to stay on it if that's what you want. So thank you. Okay. Dr. Purdue, I think she may have had to step away for a minute. So I can skip to the next question here. Lenise, this one is for you about exercise routine. How long can someone continue their exercise routine? Is it safe? Are there any exercises someone should stay away from or focus more on? I know you spoke about this a little bit previously, but if you don't mind just expanding a little bit more here.
Sure. We think it's safe to work out throughout pregnancy. I encourage people to listen to their body. In the beginning of pregnancy, people often feel pretty fatigued related to some hormone changes. And so listen to your body and work with how you're feeling. Some of the hormonal changes also can loosen up our joints a little bit. So I do caution people about doing really high impact exercises where you're jumping around a lot. You are a little more prone to pulling muscles and having injuries during pregnancy. So something to consider. And again, towards the end of pregnancy, doing higher impact exercises may be more uncomfortable as the uterus is heavier and can pull back out of alignment a little bit. In general, people tend to have some lower back discomfort towards the final trimester. So something to consider, maybe doing more low impact exercise. If you were a runner, and I've had people who run marathons in their third trimester, may want to consider walking or doing yoga or Pilates, but almost any exercise can be tailored to pregnancy. Some gyms or fitness instructors do want a release from your provider during pregnancy. And that's, something important to talk about, particularly if you have a heart or lung condition or anything that is causing you to see a high risk provider throughout your pregnancy. Are there any limitations that are specific to you?
Okay. Thank you. All right, Dr. Johnson, we will turn to you talking a little bit more about office visits. So this person is curious, how often do they need to go into the doctor once someone is pregnant, especially because of scheduling and planning for work, which I know is a concern for probably many people watching. Additionally, how long do they wait to schedule their first appointment?
Yeah, so this is a great question, especially for first-time parents who haven't had to go through prenatal care before. So typically what's going to happen is a patient will have a positive pregnancy test at home, and then they'll get a confirmation of pregnancy visit with the provider, which may be an OBGYN or their family doctor somewhere that they have a positive pregnancy test. Definitely if you're already established with an OBGYN and you call the office and say you had a positive pregnancy test, then they'll know exactly what to do. The first new OB visit typically is going to happen sometime in the first trimester, but for patients who are finding out that they're pregnant later on, there's no cutoff for when the first appointment can be. Having some prenatal care is better than no prenatal care, no matter what. So definitely, whenever you're finding that positive test at home is the time to call and make the appointment. At that first visit, the doctor will confirm all of your history. They'll talk about your medications, any other medical problems, do an exam, and then order a variety of blood tests. They'll also give you a referral for an ultrasound, where measurements are taken to confirm how far along you are. The next ultrasound typically that's happening would be later on in your second trimester, which is called the anatomy scan, where they're looking at baby from head to toe, looking at all the different organs that have been developing and taking some additional measurements. You can also find out baby's sex at that time if you're interested, if you haven't already discovered that through the different blood work that's available. And then depending on the practice that you're at, that might be the last ultrasound that you have during your prenatal care, depending on if you have any other medical issues. In terms of the rest of the prenatal visits, they continue every 4 weeks from that first visit that you have until you're about 28 weeks. And then they start to happen every 2 weeks from 28 to 36 weeks. And then from 36 weeks on until delivery, they're happening weekly. So that's just the baseline for somebody who has some medical condition. There's definitely reasons that you'd be seen more frequently, that you'd have more frequent ultrasounds. So it's all just going to depend on the specific circumstance.
Okay, thank you for sharing that schedule. All right, Dr. Jolitz, we will turn to you to talk a little bit about geriatric pregnancy. So what can someone experience with geriatric pregnancy, and what is the prenatal care for women over the age of 35?
Geriatric pregnancy or advanced maternal age is basically a pregnancy that's over the age of 35. Sometimes we say severe advanced maternal age, and that's over the age of 40. Before I get into this, because I was, thinking about this, and, there's always, increased risk factors for this and extra tests. And, I have a lot of patients a lot of women are delaying childbirth, or they're having more children later on. So I just feel like a higher and higher percentage of my pregnancies fit this category. So just because there are increased risks for it doesn't mean that you shouldn't get pregnant or have a baby. I don't want to scare anyone by this, but these pregnancies do have increased risk. So to start in the beginning of the pregnancy, maybe before you saw a provider, you are at an increased risk of having a miscarriage. So when Dr. Johnson was talking about miscarriages and chromosomal anomalies or abnormalities, that's the biggest reason. So another concern would be an ectopic pregnancy as we get older. So that is a pregnancy that is not in the uterus, but could be in the tubes or someplace else. So before you see a provider, and this is for anyone, but especially as we get older, if you have vaginal bleeding or you have pelvic pain, you definitely want to let your OBGYN know, because you need to be assessed for that. At your first visit, they will talk about genetic testing, and that's for everyone, but especially in our patients who are a little bit older having a baby, because of that risk of a chromosomal abnormality. There's multiple ways we can do genetic testing. Most of us now offer non-invasive pregnancy testing, or NIPT or NIP. And so that's done through a blood test, usually after 9 weeks. And so through that, we're able actually to see the baby's DNA in your blood, and we can screen for those genetic abnormalities. We can't check for everything, but we check for the high risk ones. And so most patients know about Down syndrome. There's trisomy, meaning 3, 18, 13, other ones as well. So a lot of patients will probably recognize, knowing what the gender of their baby was early on before they had their anatomy scan. And that's the testing that we did for that. So that will definitely be offered for you. You do not have to get it done, but will definitely be discussed at your first visit. And then they'll talk about sending you up for your ultrasound. So that's another way to assess the baby as well. And so usually in the first trimester, we measure the baby's neck for nuchal translucency. And that's a screening test for Down syndrome. And then also we offer an anatomy scan around 20 weeks to check for any abnormalities as well. And so that's pretty routine actually for every pregnant lady, but especially things, that we need to address for someone who's got an advanced maternal age pregnancy. Other things you're at risk for, high blood pressure, preeclampsia, which is when you have high blood pressure, but you also start to spill protein in your urine, among other things, gestational diabetes. So at the first visit, your doctor will kind of assess your risk. You might be at risk for high blood pressure because of a history, and you now are advanced maternal age. So they might talk about starting something called a baby aspirin to hopefully reduce your risk of that. With the gestational diabetes, you'll be screened early for that if you need to, and routinely around 26 to 28 weeks, like most patients. But if you do have some other risk factors, including your age, that might be something to discuss a little bit further. Most advanced maternal age or geriatric pregnancies are offered a growth ultrasound in the 3rd trimester, and that's just to make sure the baby's not measuring too small or too big, which you could be at risk for. You might get more ultrasounds, again, if you have additional risk factors, including your age. So that kind of depends on other factors as well. If you, again, have additional risk factors, including your age, you might get something called fetal testing with something called non-stress test. So you come in and we put you on the monitor, and we basically look at the baby for around 20 minutes to make sure the baby is reassuring. We don't do that routinely for people at 35 to 39, unless they have additional risk factors as well. Most of us are doing them for people who are severe maternal age. So if you're 40 and over, you will probably be set up for those non-stress tests before you deliver. Because of all those risks that we talked about, if you are older and you also have some risk factors, we might talk about delivering you before your due date or sooner, depending on if you develop preeclampsia or if you have high blood sugar, especially needing insulin. We might be talking about a delivery a week before your due date, just to get you delivered before things can get more complicated. If you are severe maternal age, so if you're 40 and over, we definitely recommend, and you have no other risk factors, we would definitely recommend delivery by your due date. So it is something that should definitely be discussed at your first visit. But if you're otherwise healthy, most patients do just fine. So it's definitely not a reason to be concerned about a pregnancy for most patients.
Okay, thank you, Dr. Jolitz. And I know there's a lot of testing, and related to that, Lenice, would love to get your thoughts on genetic testing. So what types of things can people learn by doing something like a genetic test?
Well, I think something people should know is that there's genetic screening also to see if you're a carrier for certain genetic conditions that can be passed on to a child. And some people have that testing done prior to conceiving, particularly if they have a family history of a genetic condition, or if they're a certain ethnic background. They may be aware of genetic testing that's available to them, or their provider may recommend something. But also in all pregnant people, there are pretty standard genetic screening, carrier status screening that we do to see if you're a carrier. Some of the most common things are cystic fibrosis, sickle cell trait, spinal muscular atrophy. That's pretty much a standard in the United States now. There's also genetic screening and testing to see if this particular fetus is at risk for genetic conditions. Screening is a combination of ultrasounds and blood tests to see if a fetus is higher risk for Down, as Dr. Jolitz talked about, Down syndrome, trisomy 13 and 18. And later we can also screen for neural tube defects like spina bifida. In someone who's having has some higher risk results than normal for their age, or someone 35 or older, there's also the additional option of genetic testing, either through chorionic villus sampling that's done in the late first trimester, or amniocentesis, where we're extracting fetal DNA from either the lining, a piece of the placenta, or the amniotic fluid, where we can actually test the baby, the DNA for certain genetic conditions. Certainly those tests are available to anyone. Some people decline to have any screening or testing, and that's fine. That's something you need to talk to your provider about, educate yourself about, and see what the best decision is for you.
Okay. Thank you. All right. So I know that we're getting a lot of live questions from the audience. So thank you so much. We'll just take 2 more submitted questions here and then go into our live questions before we end the evening. So with that, Dr. Johnson, I will turn to you for our next question. Can you discuss cerclage, incompetent cervix with preterm loss, and with a new pregnancy following a preterm loss, would you recommend cerclage in first trimester or wait for serial imaging?
Yeah, this is a good question. So for anybody who's listening that isn't familiar with it, a cerclage is a suture or a stitch that's placed around the cervix with the goal of helping keep a patient pregnant. They sometimes are planned and placed at the end of the first trimester. So that would be for a patient that has a history of a preterm loss in the setting of painless cervical dilation, which is the situation that this question is referencing. But sometimes they're placed later in the pregnancy, up until 24 weeks, when a patient is found to have a short cervix on ultrasound or exam. So like this question was getting at, for patients who do have a history of preterm loss because of painless cervical dilation, the options are either to have serial cervical lengths that are done with transvaginal ultrasounds that are confirming that the cervical length is remaining normal, or they may elect to have a scheduled cerclage placement at the end of their first trimester. There have been multiple studies that have been done to show which one of those is better at preventing preterm birth. And the results are mixed. Like so many things that we have in medicine, we don't have the perfect answer. So it's a conversation that patients with this history should have with their OB and specifically with an MFM doctor to determine what's right for them. What we do know is that patients who have this history of painless cervical dilation are at risk of having it again with another pregnancy, but there's no guarantee that it will happen. There's also the chance that they go on to have a full-term pregnancy. Unfortunately, there's not a screening test that we can perform before pregnancy occurs to be able to diagnose cervical insufficiency, to know what's going to be happening later on in the pregnancy. But always good to talk about it with your physicians to figure out what is best for you.
Absolutely. I definitely think that's a recurring theme tonight. So thank you. All right. And our last question before we turn to live questions from the audience. Lenice, this one is for you about putting together a birth plan. What are some things that a person may want to consider putting on their birth plan? And what are the benefits of a midwife?
That's a big question. I always tell people we have a birth plan, whether it's written down on paper or not. We all have an idea in our head of how we would like for our birth to go. I think, reading about labor and birth, taking childbirth classes, educating yourself ahead of time can really help allay some fears that people may have. Taking a tour of the facility where you're going to deliver is important. Sort of knowing what to expect can lessen anxiety. Just even knowing where you need to go when it's time for birth can be helpful. Talk to your provider, and you have to find the right provider for you. Be it a nurse practitioner, a midwife, an OBGYN, a family medicine doctor. You have to find someone who aligns with your philosophy about care and is supportive of your desires for labor and birth. Find out what's the norm at the facility where you're going to deliver. I have a lot of people tell me, I want water birth. That's not an option for us. And quite frankly, it's not an option anywhere in Philadelphia, even at the birth center. So knowing what's the norm, what's available, is your provider supportive of what you want? Some people want unmedicated birth, no interventions. And that's entirely reasonable unless you develop some high-risk conditions during pregnancy. Then you may have to talk to your provider and come up with a new plan. Some people are very clear that, they want an epidural as soon as possible and they want to deliver at 39 weeks. And that's something to also review with your provider. So I think being open and honest about your desires and what's available in the facility you're going to deliver is important. Also, like I talked about earlier, having a doula and meeting with them ahead of time, they can also help you develop your birth plan.
Okay. Well, thank you. I think with that, we'll go ahead and turn to our live questions from the audience. So I will jump right into it because I know that we've been receiving a lot. So whoever wants to chime in and answer the question, feel free to do so. This will definitely just be an open discussion here. So this person is wondering, I'm 5 weeks pregnant and I have lower abdominal pain. Is that normal? Anybody want to comment here?
Sorry. I think you have to evaluate the pain. Is it a slight little twinge if you're moving around, or are you feeling doubled over in pain? Is it associated with any bleeding? Is it at rest? Is it with activity? It's certainly something worth discussing with your provider. If it's causing you concern, we're there, we're available. Even if your provider's not immediately available, most offices have nurses who can take calls and refer questions to providers.
Okay, thank you. All right, this next question here. Are there any studies on drinking alcohol during the first 30 to 45 days of pregnancy before a woman knows that she's pregnant, and any known adverse effects on the fetus. So whoever wants to jump in regarding alcohol early on in the pregnancy.
We have a lot of studies that, show fetal alcohol syndrome and, or effects on the pregnancy. So, across the board, we don't recommend alcohol during pregnancy. And the more you were drinking, that kind of, increases the risk of things that could happen. Now, that being said, a lot of women drink before they know they're pregnant, and most of those pregnancies are just fine. So you're really looking at someone who might be like a heavy drinker or, abusing alcohol or something like that. But I have a lot of patients show for their first visit and they feel guilty. They just said no, they had some drinks or they're socially drinking. And that's really never a concern. So, we always recommend as soon as you know to stop drinking. Yes, we have studies, but it's probably a low concern for most people who are just kind of socially drinking and accidentally drink during their first trimester. Because most pregnancies are not planned. So most of us are out, drinking. So.
All right. Well, thank you. Next question, and Dr. Jolitz, this one might be a follow-up for you here, as I know that you're talking about Botox earlier in our discussion this evening. This person is wondering, is Botox okay if you are currently getting it for chronic migraines?
I've had a few patients over the years, and it's usually a discussion where they stop it and kind of address some other treatment options. I don't think I've had any patients continue it during the pregnancy. Again, it is a paralytic in terms of muscles or paralyzing your muscles. So yeah, I guess if it was like the only thing that was working and your migraines were uncontrollable, it might be a discussion, but I've never had a patient continue it during the pregnancy.
Okay. All right. Next question here. This person is wondering, what do you think about inositol before and throughout pregnancy? Any reaction?
I saw that question come up in the little Q&A, and so I did a quick little Google search, looked at the sources that we go to. It's definitely not something that our governing body, the American College of Obstetrics and Gynecology, has put out any guidelines on. That's where the majority of us turn to when we're looking for clinical, evidence-based clinical decision-making tools. But there's definitely been studies that have been done on it. The information that's out there is very, very limited. The evidence is very poor. It may help increase fertility. Specifically, they were looking at women who were undergoing IVF and had PCOS, and there was possibly a slight increase in the fertility rate. So the likelihood that the woman got pregnant, and possibly a slight decrease in the rate of miscarriage after a patient got pregnant. Is that enough for all of us to say every pregnant patient needs to be taking it? Definitely not. Do we have enough information to say that it's safe to be taking in pregnancy? Maybe. I think that that's another question that's good to talk with your provider more about, gives you a chance to understand more about what's going on. Unfortunately, I don't think that's going to be the magic bullet that's going to help women or people who are struggling with pregnancy achieve that goal.
Okay. All right. This next question is about diet. So how far along in your pregnancy should you be cautious about your diet? So for example, raw fish, unpasteurized milk, etc.
I think from the start of pregnancy, these are things we counsel people about. I didn't talk about this earlier, but with certain types of fish, king mackerel, tilefish, we worry about the levels of mercury in those types of fish, and recommend that you don't have those types of fish, or you don't have more than 6 ounces of tuna a week. With raw fish, I mean, I think probably women in Japan eat raw fish every day, but the recommendation in the US is no raw fish when you're pregnant. And no unpasteurized milks, juices, cheeses. When you're pregnant, there is a risk of listeriosis, which can be associated with pregnancy loss. So certainly a time to be a little more careful about food choices and pasteurization.
Okay, thank you. All right, our next question here, and thank you. Feel free to keep sending in these questions as they're great. So the next question, what are the risks of switching an OBGYN at some point in the middle of the pregnancy? So any risks that you'd like to highlight there?
I think the hardest thing is just knowing what's already been done during your pregnancy, your health history. Some people need to change due to a move or higher level provider, or there's several reasons which might affect or motivate you to change providers. But making sure you bring all your records and documentation of what's been done in pregnancy is really important, because the biggest risks come when we don't have that information and we're not aware of a problem that could be dangerous. And trying to do that in a short, work up a person's pregnancy in a shorter time period can be challenging as well.
I agree with Dr. Purdue. It's usually communication is where the issue with a transfer comes. And sometimes it's a patient that's like extremely high risk, that maybe the transfer is not a great idea, but that's usually not an issue. Transferring the last minute is usually never a great idea, but that usually can be safely done.
Okay, so communication, that sounds good. Thank you. Okay, Lenise, this question is for you. And know you mentioned this earlier in discussion, but what is the role of the midwife as opposed to the doula? So if you could kind of talk about both there, that would be great.
Sure. Like I mentioned earlier, a doula is a trained labor support person. They have no medical role or healthcare role other than to be your support person and your advocate. There are different types of midwives in the US. In Pennsylvania, the only midwives that are licensed are certified nurse midwives, which is what the midwives in the Jefferson, all of the Jefferson sites are certified as. We have master's degrees in nursing, have done advanced training in labor and birth, but we also do prenatal care GYN visits. We sometimes take a more holistic approach and whole body, mind and spirit approach to pregnancy. But again, finding the provider that is most aligned with your beliefs and desires is what we find most important.
Okay, thank you. All right, a question about IVF here. This person is wondering, does the IVF process allow you to select the gender before insemination? Any response here?
So when you're going through the IVF process, you can elect to go through something called pre-implantation genetic testing, which is when the embryologists are taking teeny tiny cells from the embryo that's been created without harming the fetus that is going to be developing, to look at a whole bunch of different things. Specifically, you're doing it for patients who have a higher risk of passing on dangerous traits to their children, especially if both parents are carriers. And it also, one of the other pieces of information that it gets you is the baby's gender. So if you are in a situation where you have multiple embryos that are equally good in terms of their genetic quality, then you would be in a position at that point to be able to choose the gender. But typically, it's not recommended to go through the IVF process just to be able to choose the gender, because there are many risks and costs that are associated with that compared to somebody who's able to conceive naturally.
Okay, thank you. All right, another diet related question here. This person is wondering, can you continue intermittent fasting while pregnant?
Yeah, I think this is another listen to your body. I certainly have had people who can do intermittent fasting, but may need to adjust their fasting times throughout pregnancy. Often need to spread calories out throughout the day. in the first trimester, you don't need really any additional calories. And in the second and third trimesters, calorie intake only goes up by 350 to 450 calories. So not huge quantities of food, but you may find your body just doesn't tolerate, going a 12-hour stretch without eating or drinking. So common sense, listening to your body, and talking to your provider if you're starting to notice any symptoms.
Okay, listen to your body. Thank you. Okay, are beta blockers, this person occasionally uses them for public speaking. Are they safe to use during pregnancy?
Absolutely. We use them a lot for blood pressure control during pregnancy. So if that's something you would need rarely during the pregnancy for public speaking, that would be perfectly fine. But we usually use it for an actual, for medical reasons, for like controlling your blood pressure during pregnancy, or there's a few other things we might use it for, but that is definitely considered generally safe during pregnancy.
Okay. A question here about migraines. I know we mentioned this earlier when talking about Botox, but this person's wondering, do migraines typically get worse during pregnancy? Not sure if there's any data around that.
I think this is patient specific. There's no, we see that migraines can either get better, become more frequent, or get more severe, and it sort of varies among patients. There's not a mass, something that's consistent among all patients. Especially depends on the triggers for migraines. If people have specific triggers, some people might have migraines with menstrual periods and things like that, and so those can be affected differently than other types of migraines.
Okay. All right. Our next question here is about average time to conception. So this person is wondering, is there a average time to conception that you know of for a woman who is in her late 30s?
I don't really have an exact average time, but if you are over 35 and have regular periods, meaning you're ovulating regularly, you could try up to 6 months. And someone discussed this earlier. So, if you don't conceive within that 6 months, and at that point, then you deserve a discussion with your OBGYN or a infertility consult at that point. But most people, especially if you're younger, will conceive with. That's why the 1 year time frame is for people under 35, because most people conceive at that point. And so 35 is definitely, you get about 6 months to try for that.
Okay. All right. This next question here is a little specific, but this person is wondering if there are any indicators that raspberry leaf supplements can help the mother during delivery. And if so, when should it be started? Any reaction to this question?
Sorry, my battery is dying and I don't know why, because I'm plugged in. Certainly midwives have used red raspberry leaf tea as a uterotonic or a uterine preparation, typically around 34 weeks gestation. No hard evidence that it works. Certainly not found to cause any harm, though.
Okay, thank you. And if your battery dies, we know what happened. Okay, next question here. What if your cycle becomes longer and your menses are lighter or less days? Is this indicative of an underlying issue, and can it affect fertility? So fertility related question here.
The biggest concern if you're having a change in your cycle is that then you would be ovulating less frequently, or possibly having anovulatory cycles. So it's definitely something that's worth speaking with your provider about. There might be specific lab testing that you need to do depending on your age. Sometimes that's something that we see as women approach perimenopause. So there's all sorts of considerations that we'd be thinking about if a patient is coming to the office with these concerns. Definitely a reason to schedule an appointment and see an OBGYN.
Okay.
All
right. Oh, yep. All right, our next question here. Does uroplasma have any impact on getting pregnant or having a baby?
I've never seen any data that it harms any fertility or pregnancy. I don't know if anyone else has seen anything else, but I would have no really concerns for that in terms of pregnancy or pregnancy complications or anything.
Okay. All right. Next question here is about a comprehensive list that this person can review of midwives or doulas to select from, or will they be assigned to one upon their first visit?
Every Jefferson hospital in the region has its own individual midwifery practice. And you can schedule appointments with all of the midwives that are seeing patients in that office, or some people try to see just one provider, and depending on your schedule and the days that they're available. Most practices work in that call schedules or coverage of labor and delivery is rotated amongst all the practitioners. So the person who, and this works also the same way for OBGYNs, the person that you see most in the office may not be the person that's at the hospital when you're in labor or birthing. For doulas, doulas are something that you, most people hire either on their own or work through their insurance agency. There are also volunteer doula programs in the community. So that's something that I know our office keeps a list of, but it's certainly not a comprehensive list throughout the region. But talk to your provider and they can forward a list to you. We do a lot of my chart messaging for that sort of thing.
Okay, thank you. Yep, head to my chart. Okay, question about PCOS. With PCOS and infrequent periods, should I see an infertility doctor even if I'm not attempted to get pregnant? How long before wanting to get pregnant should I see an infertility specialist?
I would say that it's definitely worth it to try naturally before, depending on your age. It's definitely worth it to try naturally before jumping to that infertility specialist. Women with PCOS are still ovulating at times, or there's medications that a generalist OBGYN could prescribe to help induce ovulation without needing that next step to see a specialist. That being said, if that's something that you're interested in, if that's something that you have insurance for, or you are interested in pursuing regardless of cost, then just talk to your OBGYN, get a referral, or just self-refer. They're there and would be able to see you as well.
Okay, thank you. All right, a question here about mental health medications, which I know we touched on earlier, but this person is wondering, what about ADHD meds specific to Adderall? So does it affect pregnancy, and should you stop while pregnant?
So I have a lot of patients on Adderall. The way the medication works is it constricts or tightens your blood vessels. So the concern is that it could affect the pregnancy, usually later on. So it could cause your blood pressure to rise, or that could affect how the baby grows. Most of these babies do perfectly fine. Your provider, if you decide you want to stay on it, might order a growth ultrasound later in the pregnancy to make sure the baby's growing fine. But it's always a discussion I have at the first visit. So that would be a discussion you have with your provider. Do you really need the medication? How are you doing on it? Some patients decide they want to wean off to see how they do. Some people cannot, function without the medication. So they need to continue it. So it's definitely a discussion to have with your provider, but it doesn't mean necessarily that you have to absolutely come off of it. I have lots of patients who stay on it. I have a lot of patients who wean themselves off of it and do fine. But it's definitely not, a hard no during pregnancy.
Sarah, I think that's something that most people should know about any medication. There have been ethical concerns throughout history of doing, research on pregnant people. So a lot of the information we have about medications in pregnancy is based on case studies or registries where people who've used a medication in a pregnancy, we look at the outcomes of their pregnancy. So a lot of times the information we have is it's probably safe. So it's something you need to talk about with your provider. What's the risks and benefits to you? Can you function without this medication, or is this something absolutely vital to your health? And that's a decision you need to make in conjunction with your provider.
Okay, thank you both. Okay, a few more questions here, and then we will wrap up for the evening. But again, thank you so much for all the questions coming in. This one here is about prenatal vitamins. So when should I start taking prenatal vitamins if I want to begin before pregnancy, perhaps like once I get off birth control?
I say start them.
Yeah,
They're
never
multivitamin.
sure.
They're totally safe to take at any point, whether or not you're looking to conceive. We do recommend starting them at least 3 months before conception, so that specifically your supplies of folate, folic acid are at their highest. Sorry if you can hear my dog barking. And that's what's important for those initial building blocks of baby, specifically the spinal cord going up to the brain. So that's the reason that we recommend starting the prenatal vitamins earlier. And there's no harm in starting them even while you're still on birth control, just to make sure you have those 3 months covered.
Okay, thank you. All right. Are there medications or treatments to delay menopause, stretch fertility to mid to late 40s? Wondering about the possibility of getting pregnant after 40 without IVF. And whoever wants to jump in.
That would be really cool if we could do that, but there's not really anything that exists right now to achieve that. Your eggs are the limiting factor here. As you get older, your eggs get older. And like we've talked about, we get concerned about their genetic health. There's much higher risk of chromosomal abnormalities, making it less likely to have a successful pregnancy as you age. Your uterus doesn't really age. If you do go through IVF, there's women who there's plenty of risks that are associated with those women in their 50s. I've worked with REIs who've talked about women who are pregnant through IVF in their 60s. Unfortunately, if your egg supply has dwindled at that age, then that's IVF is going to be your only option, or with typically then at that point using donor eggs.
Okay, and we're just about at time here, but I will have one last question. This again is going back to prenatal vitamins. Any recommendations? So whoever wants to chime in here, but this person is just looking for some recommendations of prenatal vitamins to take.
There's usually a brand that's covered by insurance, so that would be great just for cost reasons. A lot of them all contain the same ingredients in them and provide the same the same goals, which is the folic acid is the main thing, and then just some other standard vitamins that are found in a daily vitamin. But it's important to have folic acid, and some people might even need some iron as well in their prenatal vitamin. But there are a lot of fancy brands out there that might charge you extra, but honestly, you really just need, they all contain the same things. And so looking into what your insurance covers, we usually order the same generic for everybody and allow the pharmacy to fill what aligns with your insurance.
Okay, well, thank you. And I think that about wraps up our discussion for this evening. So thank you, Lanice, Dr. Perdue, Dr. Johnson, and Dr. Jolitz for your time this evening. A lot of great information was shared about planning for pregnancy and even beyond. And thank you all for attending and submitting such great questions. I know I learned a lot, so thank you. We will be posting an event survey so you can let us know your thoughts. Was this helpful? Are there any other specialties you would like to hear from? Your feedback will bring more virtual events like this to you, the patients. If you would like someone to contact you directly to schedule an appointment with a Jefferson Health provider, please fill out the last question in the event survey. We do have more wellness webinars coming up soon. If any topic is of interest to you, be sure to sign up. A recording of this event will be sent to you so you can rewatch at your convenience. And if you would like to view other wellness webinar series events, please visit our Jefferson Health YouTube channel at youtube.com/Jefferson Hospital. We have everything from back and neck pain to robotic surgery to planning for pregnancy and much more. If there is anything anyone here at Jefferson can do for you, please reach out to us. Thank you once again for joining, and please be sure to stay safe and healthy. Have a wonderful evening.